Hello and welcome to day one of EULAR 2021. My name is Professor Douglas Veale. I'm Professor of Medicine and Consultant Rheumatologist from University College Dublin. Today, the EULAR 2021 Virtual Congress got underway, and I'd like to review what I felt were some of the key sessions and papers of interest from the CSF perspective. There were some terrific sessions today covering recommendations, real-world data, clinical results in RA and other indications such as psoriatic arthritis, as well as discussions on difficult to treat patients and pain, and of course, don't forget COVID. The CSF's own Professor Ian McInnes opened the Congress with an insight into the work that EULAR has been doing over the past year. It was fascinating to hear Ian's perspective and that of the role of EULAR as it played out in response to the COVID crisis. It has been a remarkable success in advocacy in favor of people with rheumatic and musculoskeletal diseases, which at the end of the day is who we practice medicine for. Ian also discussed the ongoing success of the EULAR School, the EULAR Research Centre, and the new agenda for gender equality in academic rheumatology in Europe. It was a great session and definitely one to catch up on if you missed it. Following Ian's opening session, the scientific program got underway with the EULAR recommendations session. Here, Robert Landwehr provided an update on the recommendations on the management of rheumatic musculoskeletal diseases in the context of the SARS-CoV-2, and Dr. Alessio Aluno presented the points to consider on COVID-19 pathophysiology and immunomodulatory therapies from a rheumatology perspective. Both of these sessions were very informative presentations and I think very pertinent to our own practice. In relation to the real world data, which is where we practice rheumatology on a day-to-day basis, there was a wealth of real world data at this year's Congress. And I've selected 3 posters from today's sessions that I found particularly interesting. The first is also one of the chairman's picks from day one, and is from Gilbert and colleagues, who examined the real-world effectiveness of baricitinib in the Swiss Rheumatoid Arthritis Registry. This registry examines over 1,000 rheumatoid arthritis patients treated between 2017 and 2020, and looks at outcome measures including drug maintenance over time and response rates at 12 months. Interestingly, this poster shows that drug maintenance is significantly shorter for TNF inhibitors compared to baricitinib, but not for the patients treated with OMA compared to Bari. So the differences were larger for the biologic DMARD naive patients, and rates of low disease activity and remission did not differ significantly between groups at 12 months. So in conclusion, treatment with baricitinib after a conventional DMARD had at least similar outcomes as alternative biologic DMARDs. From Switzerland, we moved to Argentina, and a poster from Ramira Gomez and colleagues that described the effectiveness of tofacitinib in patients with rheumatoid arthritis from multiple public and private treatment centers. This was a retrospective observational study looking at over 160 patients from 10 medical centers across Argentina. They looked at a number of outcome measures, including disease activity, both MTX and PDN use, and also prognostic factors for clinical remission at 3 months and tofa monotherapy at 12 months. The results showed significant reduction in disease activity and MTX and PDN requirement with tofa. Remission significantly increased from baseline to month 3 and month 6, and previous biologic therapy was associated with clinical remission. So again, in conclusion, tofa effectiveness was observed in clinical response and in dose titration, or withdrawal with methotrexate and PDN. My third pick of real-world data today is a poster from the Gibovsky group, which assessed the effectiveness of UPTA at 3 months in a US patient study. This was taken from the UR-NICE database, rather aptly named, I think. It's an observational study to assess characteristics of US-based RA patients, and they looked at over 250 patients in this study receiving UPTA and its effectiveness in clinical practice at 3 months. Outcome measures, including CDAI and other disease activity measures, and also patient-reported outcomes. Patients treated with TOFA previously had longer duration of rheumatoid disease and also higher steroid use. UPTA-treated patients showed an improved disease activity scores and also improved PROs after 3 months. And there was similar effectiveness seen in patients with or without prior TOFA experience. As you would expect, there are a huge number of abstracts submitted that focus on our clinical results in rheumatoid arthritis, as well as other indications. There were 4 posters in particular that caught my interest today. And I'd like to start with a study from the SELECT PSA 1 and 2 phase 3 trials, presented by Sornes and colleagues, which explored immunological pathway immodulation by UPTA 15 milligrams QD in PSA patients with active disease, despite treatment with non-biologic or indeed biologic DMARDs in the context of clinical response versus non-response. This was also one of the chairman's picks for day one, and a presentation that is worth watching. If you weren't able to see it live, I'd highly recommend you try and pick it up on the recording. This poster looks at the proteomic analysis comparing the mode of action of UPTA between non-biologic DMARD inadequate responders and biologic DMARD inadequate responders, selected from the PSA Select 1 and Select 2 phase 3 studies. It is a post hoc analysis of immunological pathway modulation by UPTA 15 milligrams QD in these patients, looking at over 400 patients. The key results show that UPTA resulted in downregulation of plasma protein biomarkers associated with T cells, myeloid cells, including interferon, IL-6, and TNF-related pathways in these patients. Overall, the effect of UPTA on single protein biomarkers were broadly similar between the 2 groups of patients. And it shows inhibition of multiple adaptive and innate immune biological pathways by UPTA treatment. The next pick was also one of the chairman's highlights from the day and came from Baldi and colleagues. This group from Siena in Italy evaluated the short-term efficacy of baricitinib in reducing synovitis using ultrasound and also clinometric perspectives. It showed a rapid response to Bari in patients with rheumatoid arthritis who had an inadequate response to methotrexate and at least one biologic DMARD. It's a prospective study, a single center, looking at 30 rheumatoid arthritis patients, and essentially evaluates the short-term efficacy of Bari 4 milligrams once daily in reducing synovitis. Outcome measures including the paradoppler signal on ultrasound synovitis score, synovial hyperplasia, and also intrasynovial paradoppler signal score, a number of patient-related outcomes, markers of inflammation, as well as physical examination and ultrasound. The key findings showed significant reductions in the patient VAS for pain, which is something we always like to see. Also, the paradoppler ultrasound composite score was reduced. The overall paradoppler signal was reduced. synovial hyperplasia was reduced, as well as markers of acute inflammation, including CRP and the ESR, in response to Barry 4 milligrams once daily. Markers of disease activity, such as the patient DAS28, CDAI, and also SDAI were also significantly reduced. So this suggests that Barry is efficacious for up to 6 months with rapid onset of action and provides both clinical and ultrasound evidence of response to treatment with reduction in disease activity measures within the first few weeks of treatment. I also enjoyed the presentation from Dua and colleagues. Their poster looked at data from the Corona Registry, looking at disease activity and patient-reported outcomes after switching between an IL-6 receptor inhibitors and JAK inhibitors. This is an important consideration that I think will have a bearing on our clinical practice now and in the future. If we look at this as a retrospective observational data and looking at over 260 patients switching from IL-6 receptor inhibitors to JAK inhibitors. They looked at patient-reported outcomes, CDAI, HAC, and a number of other individual outcome measures. So the key results from this study, focusing on the switching from JAK inhibitor to an IL-6 receptor inhibitor, this resulted in significant changes for all continuous outcomes, except for HAC and fatigue. Whereas switching from an IL-6 receptor inhibitor to the JAK inhibitor resulted in significant improvement in the patient-reported outcomes only. In both cohorts, patients achieved CDAI, low disease activity, and CDAI remission, and also MCID across other PROs. So in conclusion, both JAK inhibitor and IL-6 receptor inhibitor therapies resulted in CDAI low disease activity and MCID across PROs in a substantial proportion of patients. My final pick of the clinical posters looked at a Bayesian network meta-analysis assessing the relative efficacy of different therapeutic strategies to achieve ACR 50 response at 24 weeks. And this compares the efficacy of combination therapy with biologic or targeted synthetic drugs for rheumatoid arthritis. As mentioned, it's a meta-analysis looking at ACR 50 response at 24 weeks. And they looked at over 6,000 patients. It included systematic reviews from Medline, Embase, and Cochrane Library databases looking at phase 3 randomized controlled trials, comparing adalimumab originator to its biosimilars, as well as Barry, Tofa, and Upta combined with methotrexate. The key results from this large analysis showed that Upta is more effective than both originator and biosimilar adalimumab in achieving an ACR 50. Tofacitinib is more effective than originator adalimumab in achieving an ACR 50. And Upta ranked first on probability of more likely to induce an ACR 50 response at 86%, suggesting that Upta is actually superior to adalimumab in affecting an ACR 50 response in patients with active RA and an inadequate response to methotrexate. If we look at difficult to treat patients and pain, which is of course the symptom that preoccupies our patients for most of the time and is often seen as patients as the most troublesome symptom, there's a focus among many of the abstracts submitted to EULAR this year on difficult to treat patients and pain. These are key issues that we encounter frequently in practice. So it's great to see such in-depth research on these topics at our Congress. There were 2 posters and 1 oral presentation from day 1 that I wanted to draw your attention to. The first is a poster presentation from Harano and colleagues who undertook a retrospective cross-sectional study to evaluate the incidence rates of difficult-to-treat patients with RA in Japan. What they found was that just over 9% of patients met the criteria for difficult-to-treat RA, having been treated with 1 or more biologic or targeted synthetic DMARDs. 39% of patients had difficult-to-treat RA, as defined by having failed 2 or more biologic or targeted synthetic DMARDs. And there were significant differences in the disease duration of the RA patients in the different classes of disease. They found that RA patients who were difficult to treat tended to be older, have significantly greater RA disease duration, as we might expect, and also have higher disease activity at the time of starting their biologic or their targeted synthetic DMARD. And they recommended perhaps a change in the criteria for defining difficult to treat rheumatoid arthritis. So this really does give us food for thought in this group of patients. Another great presentation came from Wilk and colleagues, who looked at pain responses in rheumatoid arthritis, psoriatic arthritis, and axSpA. The objective was to explore if pain catastrophizing score was associated with remission rates, and the results were very interesting. They looked at over 580 rheumatoid patients, 390 PSA patients, and 225 axSpA patients in a clinic in Norway. They collected variables including demographics, treatment, disease duration, global pain VAS, and a number of disease activity scores. What they found was that significantly fewer high pain catastrophizer patients reached remission compared with those low pain catastrophizers in rheumatoid arthritis and axSpA, but not in PSA. They found that the PCS was independently associated with lower remission rates in RA and axSpA, but not in PSA. So a high patient PCS may reduce the likelihood of achieving remission in RA and axSpA patients. My final poster pick of the day comes from our chairman, Professor Ian McInnes and colleagues. I mentioned the SELECT PSA1 and PSA2 phase 3 studies previously at the beginning of this podcast, and this presentation came from the same program, focused on the impact of UPTA on reducing pain in patients with active psoriatic arthritis. And this is important because, as you know, there is a theory that the JAK inhibitors do act on pain receptors centrally to reduce pain experiences in our patients. This analysis, which was a post hoc analysis of the SELECT PSA1 and PSA2 studies, compared the efficacy of UPTA versus placebo and adalimumab on pain using different assessments in patients with PSA. The outcome measures, including the PGA of pain, the MCID, BASDAI questions, and also SF36 questions, in particular around bodily pain, and questions 8 about pain interference. The key results from this study showed significantly more patients on UPTA than placebo achieved sustained improvements in most of their pain endpoints through to week 24. In addition, up to significantly improved the change in PGA for pain NRS, for BASDAI spinal pain, and for joint pain and swelling, as well as the SF-36 bodily pain and pain interference scores at weeks 12 and 24. This suggests that in PSA patients with active disease, UPTA achieved rapid, significant, and clinically meaningful reductions in pain across multiple pain assessments. So turning now to industry-sponsored content, there were 4 symposia relevant to clinical signaling today, covering a variety of topics. The Pfizer-sponsored symposium examined JAK inhibitors in RA. What, where, how, why, and when. This was chaired by Gerd Burmeister and included presentations by Liz Perkins, Hendrik Schultz-Koops, and Eileen Tan. The discussion covered the rationale for selecting JAK inhibitors. What have we learned about JAK inhibitors in RA and how they fit into the treatment paradigm? AbbVie Symposium offered a practical guide to using JAK inhibitors in the management of RA and SPA patients. Presentations from Maya Buch, Andrea Rubert-Roth, and Andrew Oster, as well as Dr. Janet Pope. This symposium addressed a number of topics, including the emerging role of JAK inhibitors, understanding and managing infections, and understanding the benefits and the risks of JAK inhibitors in the treatment of RA and SPA patients. So Professor Roberto Caporali chaired the Lilly Symposium, exploring global Olumiant experience in treating RA, different continents, different circumstances. Roberto was joined by Peter Taylor and Reiki Alten to look at the long-term treatment results and real-world experience of Olumiant in the treatment of rheumatoid arthritis. Finally, Galapagos brought us the first of their 2 symposia in Darwin's footsteps, continuing evolution of RA patient care as we adapt to a changing environment. Professor Laura Gosek was in the chair in this symposium and was joined by Professor Peter Nash and Peter Taylor to discuss how outcomes for patients could be optimized in a more virtual world. So a busy day 1 at EULAR 2021, and great to see so much relevant cytokine signaling content here. I hope you've enjoyed this roundup of day 1. If you haven't done so, you can download our EULAR 2021 highlights brochure from cytokinesignaling.com to see the abstracts that we've selected for you for the whole of the Congress, along with our chairman, Ian McInnes's picks. Elena Nikiforou will be with you tomorrow to discuss the highlights from day 2. All that remains for me to say is thank you for joining me today to cover day 1 highlights, and please do enjoy day 2. Bye for now.